Dementia is an umbrella term for conditions that cause impaired cognitive functioning and result in a decline of previous level of function. For example, Alzheimer's disease describes the initial pathological changes in the brain before symptoms appear through to the time when dementia has been caused by these brain changes. Similarly, Lewy body dementia is caused by abnormal deposits of protein, Lewy bodies, into the brain, which then affect chemicals in the brain and can cause symptoms of dementia. Globally, 35.6 million people were estimated to be living with dementia as of 2002. However, the World Health Organization has found that the rate is growing at an estimated amount of 7.7 million new cases each year, and the estimated population over the age of 60 is projected to surpass 2 billion by the year 2050. Individuals in the U.S. have an estimated prevalence of 1.1% between the ages of 60 to 64, which then increases to 47.5% for the oldest age group, 90 plus. While age of onset is typically over the age of 65, there are rare cases of young onset dementia. However, these cases are so rare as to make it difficult to provide accurate prevalence estimates, since surveys would have to have an incredibly large sample size. According to the Alzheimer's Association, around 4% of Americans with Alzheimer's have a younger onset, or approximately 200,000 individuals under the age of 65. Likewise, in a 2014 report on dementia in the United Kingdom, it was estimated that 42,325 people have been diagnosed with early onset dementia, or around 5% of those with dementia. Although currently diagnosis of Alzheimer's is only definitive at autopsy, in 2011 new guidelines were adopted by the Alzheimer's Association and the National Institute on Aging for diagnosing Alzheimer's both at autopsy and through brain imaging using biomarkers. While biomarkers have only recently become well recognized as having the potential to diagnose individuals with dementia, this shift in guidelines signifies a wider acceptance and a priority for future research. These guidelines outlined a previously unacknowledged preclinical timeline of disease for Alzheimer's, which will undoubtedly affect research priorities in the future. There are many theoretical risk factors for dementia, and the most well-established link is with the aging process. In individuals with late onset Alzheimer's disease and dementia, aging-related factors such as the gradual failure of neuroprotective or protein clearance mechanisms may contribute to symptoms. However, genetic factors may override the necessity for the aging process in individuals with a younger onset and accelerate the accumulation of pathogenic proteins in the brain. Other factors that may be associated with Alzheimer's disease are head injury, low educational levels, hyperlipidemia, hypertension, homocystinemia, diabetes mellitus, obesity, and inflammation. Although all of these are important factors for investigation, it is the relationship between dementia and obesity that has garnered particular attention with researchers of both the Whitehall 2 and Framingham Heart cohort studies. One group of researchers examined Framingham Heart study participants who were over the age of 60 and free of dementia at the outset. They followed them for up to 10 years into the future to determine their incidence of dementia and Alzheimer's disease. They found that while there was no linear relationship between physical activity and the development of either dementia or Alzheimer's disease, there was a threshold, and those that were physically less active had an increased risk of incident dementia. A similar study of the Whitehall 2 cohort over the course of up to 28 years found no association between physical activity and the risk of dementia between 28 and 10 years prior to diagnosis. However, this study did discover that individuals subsequently diagnosed with dementia were more likely to have a decline in physical activity up to 9 years prior to their diagnosis, with a difference in moderate to physical activity of negative 0.39 hours a week. This was significant with a p-value of 0.005. This may indicate that there is reverse causation and that it is not physical inactivity that is a predictor for dementia, but rather physical activity declines as part of the preclinical phase of dementia. This may influence future prevention and surveillance efforts, although more research is necessary. Current drug treatments aim to increase the levels of the neurotransmitter acetylcholine, which is depleted in Alzheimer's patients. However, there is no convincing evidence that this will prevent or reverse the disease. Although drug treatments upon diagnosis are available for dementia, these treatments generally aim to slow the progression of the condition, and cognitive therapy can be helpful in reinforcing appropriate behavior. Likewise, the core care for dementia seems to be relatively uniform between states, with emphasis being on symptom alleviation and prolonging the early stages of the disease before progression. In recent years, there has been a push to decrease the amount of antipsychotic drugs prescribed for those with dementia. However, few of these treatments are currently funded publicly. A recent study with a small sample showed a significant decrease in antipsychotic drug orders in an all-female care unit when DAW therapy was applied. However, possibly due to the lack of understanding as to the how and why this effect is seen, or due to the small sample size, there has been no change to the funding allocated for non-traditional therapies like DAW therapy. Many individuals who suffer from dementia are older and may benefit from treatment through federally funded Medicare. Medicare has covered care planning for individuals who were recently diagnosed with cognitive impairment since January 1st of 2017. This means that a health professional can evaluate their needs and assist them in planning their care and treatment, and includes informing individuals of current clinical trials they may be eligible for and care available within the community. An annual wellness visit also became available for Medicare beneficiaries as of January 1st, 2011, as part of the Affordable Care Act. Both of these initiatives aim to diagnose elderly individuals earlier and increase access to preventive and earlier treatments. Individuals who have been diagnosed with dementia may also enroll in a special needs plan, which are Medicare Advantage plans, specially developed and suited to those suffering from dementia. Additionally, while 100 days of skilled nursing home care may be provided by Medicare under limited circumstances, long-term nursing home care is not provided. Medicare will also not cover over-the-counter nutritional supplements and vitamins, adult daycare, or incontinence supplies. Unfortunately, all of these may be important costs for individuals suffering from dementia. In 2011, President Obama signed the National Alzheimer's Project Act into law. This released an additional $50 million in federal research funding for Alzheimer's during fiscal year 2012. States with large populations of individuals affected by dementia, like Florida and California, are approaching the growth of this condition in similar but separate ways, and are both taking proactive steps to improve prevention, treatment, and care for individuals and carers affected by dementia. California, which currently has the largest amount of individuals with dementia in the U.S., has laid out an action plan for 2011 to 2021. This plan includes many ambitious changes, such as providing state-approved forms for a power of attorney for healthcare and physician orders for life-sustaining treatment at no cost to consumers via public libraries, resource centers, and easily accessible websites. The California Task Force also further recommend access to websites and call centers 24/7 so that individuals seeking information will always have someone to speak with. Informational resources and educational materials are also planned to be made in appropriate languages with fonts that are easily read by all individuals. Another main goal in California is to promote accessibility on public transport to diminish feelings and realities of isolation. More support for caregivers and training for healthcare professionals are also recommended. Florida's public care for dementia is organized through the Department of Elder Affairs. In 1985, they created the Alzheimer's Disease Initiative to provide support services and counseling, consumable medical supplies, memory disorder clinics, a brain bank for research, and model daycare programs to test new care alternatives. This brain bank is of special importance for researchers and also for family members, since autopsy is still the only definitive way to diagnose Alzheimer's disease or related dementia. Respite for caregivers is also included through the Alzheimer's Disease Initiative in order to assist in community building, education, and support for caregivers. The Department of Elder Affairs also provides resources for communicating and explaining Alzheimer's and dementia to younger family members and children who may not be able to grasp the disease, as well as a number of other informational pamphlets in a variety of languages. Florida established the Purple Ribbon Task Force within the Department of Elder Affairs to create an Alzheimer's disease state plan. This was established after a needs assessment was conducted to determine how individuals of varying cultural backgrounds are affected, which services are available, and where care is currently lacking. Upon reviewing their findings, the task force recommended over 100 different changes. Among these, it is recommended to provide tax credits to businesses to assist employees using adult daycare services for family members, ensure better access to memory screening and support, the creation of specifically designated memory disorder clinics, and to provide greater access to dementia-specific services and resources for Hispanics and Latinos, African Americans, and families in rural areas. An often overlooked population requiring further investigation are caregivers in general, and specifically those caring for younger onset dementia patients. Most caregiver support is currently directed toward individuals caring for those suffering with older onset dementia, and little research into support is directed to the spouses or loved ones of those caring for early onset dementia. This problem is compounded by the lack of sensitive diagnostic measures for early stages of the disease, which results in a prolonged period where families and loved ones struggle with their behavior. During this period, family members may misunderstand the symptoms and interpret them as a midlife crisis or substance abuse, and general practice physicians may misdiagnose the individual with depression, anxiety, or other psychiatric disorders. This may have a detrimental effect on the caregiver's relationship with the individual, even prior to the actual diagnosis of dementia. The way that caregivers cope with stress has previously been shown to significantly predict cognitive decline for individuals with dementia. As a result, improving their quality of life and ensuring that caregivers feel valued and are recognized for the role that they play in an individual with dementia's life is vital to dementia treatment and care in a more general sense. As of 2017, over 30 states have instituted the Caregiver Advise, Record, and Enable Act. The act requires hospitals to record the name of the caregiver on the individual's medical records, inform the caregivers when the individual is being discharged, and provide the caregiver with education and instruction of medical tasks needed at home. In this way, it lends emotional and training support for individuals going through what may be a very large life change. As of 2017, Florida is not among the states to institute the CARE Act. As previously mentioned, Florida does offer respite for caregivers through the Department of Elder Affairs, which allows for counseling services and training programs. However, it does not offer the legitimacy and empowerment of offering caregivers a real role in case of hospital visits or emergencies. Adopting the CARE Act would allow a degree of legitimacy and support that is not currently offered, which in turn may benefit the individuals that the caregivers serve. There is a racial/ethnic component to dementia that is not yet well understood. One cohort study of 2,351 Kaiser Permanente Northern California Health Plan members who were over the age of 90 found that during the 5-year follow-up period, Black individuals had significantly higher risk of developing dementia than their white counterparts. The same study also found that Latinos had a higher rate of dementia than whites. Despite these higher rates for minority ethnic groups, and despite the fact that these individuals comprise 28.4% of the U.S. population, these individuals only comprised 8.9% of the participants in a Memantine clinical trial and were found less likely to be judged provisionally eligible or to take part if they were eligible for a Tecrin clinical trial. The same researchers found that only 3.6% of participants were from a non-white ethnic group in a meta-analysis of the Alzheimer's Disease Cooperative Study randomized control trial and 4 industry-sponsored randomized control trials. Treatment and prescription practices for ethnic minorities vary considerably and are in need of greater research to determine the underlying reasoning behind this. 3 studies found that Black patients were only half as likely to be prescribed cholinesterase inhibitors as white non-Hispanics. Of these studies, 2 compared odds ratios after adjusting for socio-demographic characteristics and level of comorbidity and cognitive impairment, and found that African Americans were 30% less likely to be prescribed cholinesterase inhibitors. These researchers also found similar ethnic discrepancies with the rates of memantine prescription. In order to adequately address racial and ethnic disparities in dementia treatment and care, each individual problem should be taken into consideration. Minority populations are frequently diagnosed later in dementia's progression, meaning that treatments have a lower likelihood of being effective. In order to address this, health awareness campaigns should be developed with key stakeholders from minority communities involved throughout the development and implementation. These campaigns should seek to reduce stigma associated with dementia and should emphasize the greater likelihood of positive outcomes with earlier treatment. If necessary, any barriers to treatment should be addressed through appropriate legislation. In order to address the underprescription of appropriate treatments, physicians should be consulted to research why these patterns are being seen. Medical professionals should also be encouraged to review their own prescription patterns by race to ensure no preferential trends are occurring. Lastly, research institutions should be encouraged to focus their dementia